episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom, and I'm joined today by my myeloma friends, including Pat Killingsworth, Gary Peterson, and Cynthia Shimlowski as co-hosts. We would like to thank our sponsor for this episode, Takeda Oncology. We're very grateful for their dedicated support for the Myeloma Crowd Radio show. This is the second in a very important series featuring the Myeloma Crowd Research Initiative. For the first time, patients, including you, are teaming up with myeloma researchers to find and fund the ideas in myeloma that could have the greatest impact for the next generation of myeloma therapies. We decided to go after high-risk myeloma. Now, I've called this a trickle-down strategy, but a friend corrected me and said it was actually a trickle-up strategy for patients that have no viable options today, either because they have high-risk features or are relapsing or refractory to existing drugs. We need new options. And if we can find solutions for high-risk patients, it is highly likely that it will work in medium or low-risk patients. And ultimately, we all become high-risk as the current arsenal of myeloma drugs stop working. So this series is truly for everyone. We asked researchers around the world to submit their proposals, and we received back 36 high-quality letters of intent. That list was then scored by our scientific advisory board, including Dr. Ola Landgren, Dr. Guido Trico, Dr. Nupa Rajay, Dr. Robert Olowski, Dr. Rafael Fonseca, Dr. Irene Gobriel, and Dr. Mike Thompson. 10 proposals were selected. We are now holding Myeloma Crowd Radio shows so you can be involved. We would love for you to understand these proposals, so please listen in, ask questions, read the transcript after the show is posted, and share it with your myeloma friends and your caregivers and family members. This is truly critical work being done in myeloma. Now, after the full proposals are submitted, the Scientific Advisory Board and the Myeloma Patient Advisory Board will together decide on a limited number to fund through patient-driven campaigns. And again, we will need your help to get the word out and share the really amazing work that's being done. So we are very privileged today to have with us Dr. Guenther Koehne of Memorial Sloan Kettering Cancer Center. Welcome, Dr. Koehne.
Thank you. Thank you for inviting me.
We are so happy to have you. Let me give us a brief introduction for you. Dr. Guenther Koehne is Medical Director of the Cell Therapy Laboratory in the Bone Marrow Transplantation Laboratory at Memorial Sloan Kettering. Pardon me. He's also Associate Member and Assistant Attending Physician in the Allogeneic Bone Marrow Transplant Service. He's Associate Professor of the Joan and Sanford Weill Medical College of Cornell University. He leads research at the BMT Department Immunology Program to develop adoptive immunotherapeutic strategies for post-transplant blood disorders. He has particular expertise in the creation and monitoring of antigen-specific T-cell responses in these patients. He's the Principal Investigator in active clinical trials using adoptive cell therapy following allogeneic stem cell transplants for multiple myeloma and plasma cell leukemia patients. He obtained his medical degree at the University of Hamburg, Germany, and has been at Memorial Sloan Kettering Cancer Center since 1996. So, Dr. Koehne, I'm going to add on. We have also with us Cynthia, and let me add Gary here, who will also be asking questions. And we will also open it up at the very end for patient questions, so you can press 1 on your keypad if you have a question there. Why don't you go ahead and begin with the background about this research, how it came to pass, and in particular, you have one patient that has a very interesting story.
Yes. Basically, it really started out very early, as you also alluded to in your introduction, that patients were referred to me from myeloma doctors that were basically not responding to the standard chemotherapy, and they had problems to convince the patient with other drug combinations, and they just asked me, is there something you can do about? And as you also alluded to in my introduction, I'm basically by heart a bone marrow transplant physician, and secondarily really involved with utilizing the immune system to fight cancer. And that idea arose then by taking on patients that had multiple relapses they had their autologous transplant, and they had relapsed disease after that. And basically, every myeloma doctor would agree that the dynamic of this disease will change once you start relapsing. And so we were really in the category of thinking, what do you do for these patients? And we have, and it was known that we have a potential curative therapy for patients with multiple myeloma or even relapsed multiple myeloma, and that is the donor-derived or allogeneic stem cell transplantation. But before we could apply this, we needed to change a lot with regard of the outcome, because the allogeneic stem cell transplantation for patients with multiple myeloma had significant limitations, and most of those are summarized as severe graft versus host disease. That's basically an immune response of the donor's T cells against healthy tissue, and the conventional allogeneic transplantation in itself had a much higher rate of graft versus host disease in patients with multiple myeloma compared to those that were transplanted for other diseases that required an allogeneic transplant. So what we needed to do, first step, is to really reduce this risk of inducing complications, graft versus host disease. And that initiated, when I was asked to take on these patients, that initiated the idea, because Memorial Sloan Kettering Cancer Center has been the pioneer of doing what we call T-cell depleted transplants. So in other words, we'll remove the T cells from the stem cell product that's collected from the donor, and with that, we reduce the risk of graft versus host disease significantly. And so this is how it started out then. So the first patient's relatively young. I remember the first one that really came to me was only 36 years old, and had already relapsed the disease, and the referring physician told me, I really don't know what to do with him. And I talked to him about the first step of introducing T-cell depleted transplants. That was, frankly, 7 years ago now. And this patient is now, as you do the math, is 43 years old and is still in complete remission at this point. So that was really the first step where we really got a little bit more excited about introducing the T-cell depleted transplant approach. And then later on, and then the second patient you alluded to, then that's my patient with a really very, very aggressive disease. We call this plasma cell leukemia, and in her particular case, it's a secondary plasma cell leukemia, where everybody knows that the overall survival is extremely limited. In fact, it's somewhat between 9 and 11 weeks with best available treatment. And so that was the next step then. After other patients that I transplanted with the T-cell depleted approach, I knew this patient had a brother who was willing to donate. It was a good match. And at this point, we knew already how to generate myeloma-specific or tumor-specific T cells. And this patient then underwent a T-cell depleted transplant and got infused with those myeloma-specific T cells 6 weeks after the transplantation. And we obtained, surprisingly enough, at this point, to be honest, we obtained a complete remission after we infused her with these cells, and that then led to next steps to develop a strategy how we really want to approach patients with high-risk multiple myeloma or advanced disease and treat them with a platform of transplantation, and then subsequently steps include the immunotherapy.
Okay, there are a lot of questions around that, I think. And I know, Cynthia, you had a question about the T-cell depleted transplants. Do you want to ask those while we have that up front, and then we'll kind of move on to the immunotherapy?
Sure. With the T-cell depleted transplants, you're taking the T cells out of the donor's, I guess, serum that's going back in it. Have these transplants been done in other types of cancers, or are they just specific to myeloma?
No, in fact, it started in other diseases. Initially, at our place, we started to do the T-cell depleted transplant for patients with leukemia, and that was the breakthrough development when we had a national study showing that the outcome of patients undergoing allogeneic transplant for acute myelogenous leukemia or acute lymphocytic leukemia had an equivalent outcome in terms of overall progression-free survival, but they did not encounter the side effects, which we summarize as graft versus host disease. So in other words, that was the first time that really we could, show that you do not necessarily need to have graft versus host disease in order to prevent relapse. And then that was the precursor here, because those patients that came to me were not willing to undergo the old-fashioned allogeneic transplant, and so with the information we had from these initial trials for leukemia, we then opened a trial to test the hypothesis whether or not we can perform the same and achieve the same outcome of patients undergoing a T-cell repeated transplantation with multiple myeloma. And in fact, that the graft versus host disease occurrence is extremely low in all the clinical trials that I'm having right now.
Do you take all the T cells out in a T-cell repeated transplant?
It is
And do patients need T cells in the future? I mean, once they're depleted, do they ever go back?
That's a key question, and the first answer to the first part is what we do is we get the product that is collected from the donor, which is a bag of 1 liter or 1.5 liters of fluid, and that's a composition of the stem cells, which you really would like to have, and then the T cells and other cells that are in the bag. What we do is we'll tag the stem cells with an antibody that is labeled to a small magnetic bead, and we'll push those through a magnetic field, and the stem cells will be pulled out and it will be enriched, and all the other non-tagged cells, including the T cells, just flush through the magnetic field, and they end up in a stem cell negative fraction, and will usually not be used for anything. So the answer is the amount of T cells is extremely low. It's not zero, it's not negative, but it's about 2,000 to 3,000 T cells per kilogram body weight when we perform the transplantation, and that amount of T cells is too low to induce graft versus host disease in the majority of all transplants that we are performing. With regard to the second part of your question, do you need the T cells after the transplantation, is exactly a matter of the strategy and the scientific approach that I'm exploring. We don't know for a fact, but obviously I transplanted a lot of patients now with relapsed multiple myeloma, and we gave, after the transplantation, T cells from the same donor at calculated doses, which we call donor lymphocyte infusions. And in some of these patients, we induced a persistent remission. In other patients that had residual disease prior to the donor lymphocyte infusion, we could induce a complete remission as a consequence of the donor lymphocyte infusion. And that then raises other questions. What do we really do with the donor lymphocyte infusions? And this leads then to what I think we will discuss at some point, to the development of the Wilms tumor antigen or WT1 specific T cells that we're now administering.
Okay, thanks so much, Doc.
My pleasure.
So I had a question also about low levels of graft versus host. In other shows that I've done, some experts have said, having a low level of graft versus host is actually good because it's a graft versus myeloma effect, but high levels are very poor. So what I just heard you say is that might not be true.
It's a provocative statement, but I have to say I think it's time to really make this statement. You do not need to have graft versus host disease to prevent relapse in the majority of diseases. And myeloma is one of those where we know already for a fact that graft versus host disease is not necessarily associated with a better outcome or with a less relapse. And that holds true for acute myelogenous leukemia as well, and for sure for acute lymphocytic leukemia. There's one disease that falls out a little bit, and that is called the CML, or chronic myelogenous leukemia, where it is established outcome that graft versus host disease prevents relapse if you have graft versus host disease. But in all the other ones and other diseases I mentioned, and primarily in myeloma, you do not need to have that. There is also a recent publication from the Europeans. It's called the EBMTR, or the European Bone Marrow Transplant Registry. They summarized the outcome of patients undergoing allogeneic transplant with for multiple myeloma and just looked at those who had graft-versus-host disease versus those who had no graft-versus-host disease, and there was absolutely no difference in the relapse rate.
Fascinating. And if you've been doing this type of allogeneic transplant, the T-cell depleted transplant, for the last 7 years, why are there not more people doing this? Because if you're avoiding this, it's critical for allo.
I'm in total agreement, and the way in the scientific community the way it works is you have to show first scientifically that you're right with what you're doing or what you're thinking, and then the other centers are potentially joining. And in fact, I'm right now at that stage where this trial, T-cell depleted allogeneic transplants followed by immunotherapy in form of donor lymphocyte infusions or antigen-specific T-cells, will open at other centers. So I'm in strong communication with other centers. That also got a little query about the fact that they had to send me all the patients. In particular, one center in Kansas University, they sent me over 15 patients by now and asked the question, why should I go to New York? Why don't I do the transplant here? And so that's exactly why I will open this trial, or they will open it there under my guidance.
Mm-hmm. Okay, and before we move on to the WT1 immunotherapy piece of it, I would like to ask if you could just give a brief overview of plasma cell leukemia, because there's primary plasma cell leukemia and secondary plasma cell leukemia, and not everyone knows what that is.
Well, in the development of multiple myeloma can occur in several stages. You might have heard about an MGUS stage or monoclonal gammopathy of unknown significance, and then you have an asymptomatic myeloma, and then you have multiple myeloma. And at the end of this whole spectrum, you can have something that we call plasma cell leukemia. So this may be misleading. It's not necessarily a leukemia compared to a real myelogenous leukemia. It's basically really the multiple myeloma cells that are now floating around in the bloodstream. And it's a very aggressive and very advanced stage of multiple myeloma. It could be sometimes that patients get diagnosed right away with plasma cell leukemia, which is called the primary plasma cell leukemia. And in other circumstances, it is the development through the stages, so that they had multiple myeloma for a while, for years, and after that it progressed to a leukemic transformation, and then end-stage multiple myeloma. And both diseases are really, every myeloma doctor will agree, have to be looked at very differently, because it's a completely different kettle of disease, because the overall survival is extremely limited. And therefore, I feel like we really need to take this into account and also come up with a more aggressive treatment approach from the very beginning.
And is that why you decided to target plasma cell leukemia, just because there are no options for these patients?
First of all, there are extremely limited options, and then second of all, the antigen-specific T cells, were needed to be tested in a scientific fashion. And if you have a disease that is really very aggressive, and you have a low threshold, then if you get patients into a longer-lasting remission that exceeds the expected time frame, then you have already something that you can show off. And then basically, I really like more the trickle-down effect that you initially mentioned, because if you can show that this works in these higher-risk categories and is safe, you may also allow then later on to apply this to patients at an earlier stage, and therefore trickle down and apply this new approach.
Mm-hmm. Absolutely. Well, maybe you would like to continue just describing the kind of the second part of this. So the first part is that you're changing the way that you do the allogeneic transplant, and the second part is that you're using immunotherapy to do that. Maybe you explain what that is and how that works.
The whole, I like to do that. Yeah, the whole principle of stem cell transplantation or allogeneic stem cell transplantation is really the attempt to utilize the donor's immune system to treat disease. And the initial stages of allogeneic stem cell transplantation were gearing towards high-dose chemotherapy with the goal to really eliminate every single cancer cell if you get lucky, and then have a better outcome. But it turned out to be that the high-dose chemotherapy is not really necessarily needed because it's not the treatment that treats the disease and can get somebody in long-lasting remission. The immune system of the donor, and particularly T cells that develop in the patient after the transplant and get sensitized in the bloodstream and learn to recognize tumor cells, are the ones that can induce a long-lasting remission and float around and find tumor cells that escaped a strong chemotherapy. These T cells have the capacity to really walk out of the bloodstream and go into the tissue and find tumor cells, and then they have the capacity to send signals to other cells and say, here is where the disease still is, come over and do something. And this led to the development then of pre-priming T cells from the donor in the laboratory to make them specific for markers that are expressed on the myeloma cells. And accidentally I discovered by following patients that got donor lymphocyte infusions after the transplantation that the majority of these patients developed a tumor-specific response against a marker that expressed on the myeloma cells, which is called W2-1 or Wilms tumor antigen 1. And this then changed the whole strategy how we approached patients with plasma cell leukemia by generating the T cells up front in the laboratory to make them specific and then infuse into the patient.
So you're taking out the donor T cells, you're engineering them basically to target this Wilms tumor antigen 1, and then you release them back into the body and they go do the attacking work.
Exactly
correct?
Right. Yes, exactly right. And the advantage is if you now have a disease like plasma cell leukemia, where patients really have few weeks or limited months to live, you have to act fast, and you want to do the transplant and follow up with something right away afterwards. You don't want to wait until the disease is back. The advantage of these T cells that are engineered in the laboratory to recognize the tumor cells during this culturing process also lose their capacity to induce graft versus host disease. And for that reason, you can give these cells at an early time point after the transplantation without having the risk of inducing graft versus host disease, but still fighting the disease by inducing a graft versus myeloma effect.
And on your video, now you have a really nice video on the Memorial Sloan Kettering website that describes this research, and we will link to that because it's really terrific. But I noticed that you were saying there was you wanted to give them 6 weeks after the transplant, but not before, because it had an impact on the graft versus host. Is that right?
That's partially correct, because you need to wait a little bit until the stem cell product is really settled in the bone marrow, and then you can follow up with specific T cell infusions. But you don't want to wait for too long until the disease comes back already, and the chance that it will be in the case of plasma cell leukemia is very high.
Doctor, I just was wondering, this is Gary Peterson, if you could take the T cells from the patient and make them sensitive to this marker.
That's a wonderful. Yes, that's a very good question, and therefore coming down again with a trickle down effect. I think it's worthwhile to try. Obviously, it's not possible to try this in patients with plasma cell leukemia because there are two aspects to it. Their own immune system already allowed the disease to develop, and the disease somehow escaped the immunosurveillance, and therefore it would take for way too long time, and you don't get these patients into remission. But it may be, and that's the trickle down, if you have somebody with an early stage of multiple myeloma and has many more years with a controlled disease, that this is a possibility, and that's something I would like to test in the future.
The other question to kind of follow that would be, you had said that these T cells from other patients or other people who lost their graft versus host capability. And as a result, could those then be just infused into a myeloma patient or end-stage leukemia patient and do the same thing without the allo or auto transplant?
The way we are doing this and generate these cells from a donor to infuse in a patient without an allogeneic transplant would not be possible, because you would need to convert the patient, or in this case the recipient, to donor chimerism, or to the immune system of the donor before you can treat. These cells would either not do anything, or they would still have the capacity to recognize the healthy tissue if you did not convert the patient to a donor immune system.
Okay, thank you, Doctor.
But there are other, I don't want to escape and switch to a completely different theme, but there are other approaches that could potentially be considered to use the patient's cells to manipulate directly and test, but it would not be possible to use donor T cells into a patient that did not undergo an allogeneic transplantation.
Okay.
And so
I have some questions with the WT1 cells. Can I ask them now?
Yeah, go ahead, Cynthia.
So the WT1 cells are expressed on the malignant plasma cells, is that correct?
Correct. Mm-hmm.
So if by chance, when you do the allogeneic transplantation, if you get the patient in a complete stringent response where there's no MRD, would they still be able to have these WT1 cells go after if there's no myeloma cells left?
Yes, well, and that really is another big advantage of using the donors or the patient's immune system and using T lymphocytes that are specific for the disease. In contrast to chemotherapy that has a known, what we call half-life, so you take the pill or you get it infused and the drug breaks down or is broken down by the liver and you excrete it, then it's over. Those T cells are just there to stay. And so there is, and I don't know exactly for how long the WT1 specific T cells may be in the bloodstream, but in this particular case that Jenny also alluded to, the patient that I transplanted for plasma cell leukemia, I know by follow-up and testing her blood that these tumor-specific T cells were in her bloodstream for more than a year and a half. And at the time when she went into a complete remission and stayed negative of all disease markers, the numbers came down, but they were still there and expressed some form of tumor surveillance. So in contrast to chemotherapy, these cells are there. They are biological weapons that are alive, and they survive usually in lymph nodes. And if the disease shows up without even knowing for us, because in between we didn't do the blood test, then they come out and they can go after the tumor cells again.
Oh, that's pretty neat. Now, are there any other cells in the body that's expressed that same WT1 receptor that these T cells may go after?
It's also an interesting development. The WT1 has been explored basically at looking at all forms of cancers. And for unknown reasons, nobody really looked into WT1 in multiple myeloma, and I just was the first to really look into this accidentally, because we have another clinical trial where we looked at WT1 in leukemia, and I applied the same methodology to look into patients with multiple myeloma, and then found out that this is really very highly expressed on multiple myeloma, and that patients develop a very strong immune response against this WT1, and subsequently they have a clinical response. There was really an accidental finding, and if you observe these, then you exploit this, and then all of a sudden you end up with a full-fledged FDA-approved trial to treat patients with this disease with these T cells.
Thank you so much.
On the W, a receptor. There was some information that we had seen before. It talked about you can go after this particular receptor, but sometimes it resides on other things that you don't want to mess up. Like for example, like it could be on all your kidney cells, so you can wipe out your kidneys with it. Did you see any off-target responses?
A very interesting and good question. We have not seen any side effects from the administration of these cells. The question with regard to kidney comes up all the time, and I'm surprised by the fact that we do not see any effect on the kidney. And you really brought it up because the Wilms tumor antigen is expressed, although at a lot lower level than on the plasma cells, which may be the reason why you don't see side effects with regard to kidney dysfunction or anything. But we have not observed, despite of treating quite a good number of patients with these cells by now.
Jenny, could I ask some questions?
Yeah, please go ahead, Pat.
Hi, Dr. Pat Killingsworth in Florida.
Hi.
And I have a couple specific questions, but first, to clarify, is so you can apply this principle to both allos and also autos, or just donor transplants?
At this point, we're just testing them in the context of donor transplants and generate the cells from the donor that also donated the stem cells.
Sure. Okay.
But the question could be, because I also observed that patients with multiple myeloma get sensitized, so they have very low frequencies of Wilms tumor antigen-specific T cells in their bloodstream. Therefore, the question could be, can you use those, take them out of the blood, grow them up in the laboratory to higher numbers, and reinfuse? That's something that we like to test in the future.
Okay, that's interesting. Now, I watched the video, and have you been able to duplicate that success yet?
Yes.
With the patient that we see in the video, for example, at Mayo Clinic, they had some phenomenal results with the measles virus, but in their second cohort, they haven't been able to duplicate the success.
Totally agree, and I appreciate your comment. No, we have. The answer is yes. So I have other patients with plasma cell leukemia, primary and secondary plasma cell leukemia, that are still in persistent complete remission. There are a few now that are more than a year out, which is a good time frame to say that's more than expected.
Oh, that's wonderful. So the implication is, if you can treat plasma cell leukemia, myeloma should be easier, huh?
That would be my conclusion as well, and so the next clinical trial that thinking ahead, because this plasma cell leukemia trial is coming to a closure because the accrual rate is just complete, will open up to patients with less aggressive disease, and so showing the safety of these cells, it would be certainly a good approach to use patients that have relapsed multiple myeloma and treat them with the same approach.
Yeah, that would be great. And I have a specific question. Being one of those patients, what I've learned, I've now relapsed 3 times. What I've learned is I'm becoming a non-secretor, and that a lot of late-stage patients are non-secretors. Are you able to include non-secretors in your trials, or are we? I'm finding just when I need a trial, I'm excluded from like 95% of the trials.
Yeah, no, non-secretors are not excluded from the trial. You just have to monitor the response by bone marrow studies, which is obviously a little bit more painful to the patient to have a bone marrow every single time to see whether or not the cells are working or the treatment is working. But in general, they are not excluded from this approach.
Oh, wow, that's great. Hey, I'm getting ready, preparing for a modified salvage auto transplant. How soon do you start accruing patients for myeloma patients?
For the auto transplant, I'm not sure this will happen within the next 2 or 3 years. We really have to test whether or not they're equally effective. Right now, I know all I can say, and I know scientifically that the donor-derived T cells can have a very good effect.
Sure, I meant, but aren't you starting to accrue for donor transplant?
Oh yes, that's in full swing. Donor transplant, that's with the antigen-specific T cell infusions is in full swing.
Maybe I should look at doing that instead. My insurance approved an auto or an allo, so maybe I should look into that.
Yes, I'd like to talk to you here in person.
Wonderful. Thank you, Doctor.
My pleasure.
So I had a question. In some of the literature, when I was reading about it, it talked about the Williams tumor 1 antigen, and it was secreting IL-12. Can you explain what IL-12 is and why that's beneficial, or what that does?
That's already the next step that we try to think about. How can we do better? The interleukin 12 basically is a substance. We call it a cytokine. It's a small molecule that is excreted by certain types of cells that we call antigen-presenting cells, or that are at the site of the disease. And what interleukin 12 can do is it can...
Whoops. I think we lost him. So let me add him.
Jenny, could you go find him for us, please?
I will find him. You never know what kind of excitement you're going to have.
There you go.
Dr. Kohne's office, this is Laura.
Oh, hi. We dropped the doctor on our call. Can you patch us back to him, please?
Absolutely. Is this Jennifer?
This is it is.
Yes. Okay, one moment.
Thank you.
Elevator music.
I'm sorry, I somehow got disconnected. I was talking against the wall, I guess.
Oh, no, we wanted to hear what you had to say about interleukin 12.
Yeah, so that's an interesting substance that's produced in the body at the site of disease, and the interleukin 12 has the capacity to change the environment around the tumor site, and also can stimulate and send signals to T cells to come to the site. So it's really a very interesting substance that could enhance the survival of the T cells at the site, and could also improve the recruitment to the tumor site, something we call homing to the site. And all in all, there is a good chance that the T cells will be there at more numbers, and they will be around that site at longer time periods. And that then, knowing that, introduce the idea whether or not you can just armor those Wilms tumor antigen-specific T cells with a gene that allows the T cells to produce interleukin 12 at the site. And so that's the next step that we're thinking about to introduce, to modify the Wilms tumor antigen-specific T cells with a gene that allows to produce interleukin 12. And that may even have a better effect than the Wilms tumor specific T cells that I'm utilizing now. And that, in fact, would also be testable in the autologous setting, because if you now can use the T cells from the patient, make them tumor specific for WT1, and introduce the interleukin 12 gene and reinfuse those, then we may ask the question, is this an effective treatment that does not require the allogeneic transplant, or it could at least utilize to find out whether or not it's safe, and how strong the immune response you can achieve with this approach.
So the IL-12, that specifically armors the T cell so it can be eliminated. Is that right?
Yes.
I had the feeling that it was like a mini bomb attached to the T cell.
You can say it like that. Definitely, it's something that changes the environment. We call it an inflammatory or pro-inflammatory cytokine that once the T cells home to a site in your body where the disease is present, then it gets released and the T cells get more active. There are inhibitory cells around the tumor site, and so there is something that is called immune escape. The tumor cells are usually a little bit smarter than we just think they are, so they can shut down the response to immune response to T cells, and this interleukin 12 would be able to reverse the effect, so that they are not protected.
Like a little detonator.
Exactly. That's exactly how we can look at it.
Oh, okay. Thank you. That's pretty neat.
Yeah, we have to test whether or not it's as effective as we hope, but we have some evidence and some background that is very promising.
Well, could you take us through your process? I mean, you're building upon what you've learned already, and now you're trying to, it sounds like, just super boost what you're already doing. So can you walk us through the original single patient use clinical trial, the clinical trial that you just recently ran, what you have planned in the future?
Yes. So it's basically a learning process that we have been through, and every time we'll treat a patient or more than one, we learn something, and there are some scientific results that always surprise us, and if we take notice of it, we just try to take advantage and then build this into the program. So the first step really was the T-cell depleted transplant for patients with multiply relapsed myeloma. They underwent the transplant. They got T-cells, unmodified T-cells or donor lymphocyte infusions from the same donor, and with these T-cells we could observe immune-specific responses that then led to the detection of the Wilms tumor antigen expression on the myeloma cells and the discovery of immune-specific T-cells that are derived from the donor lymphocyte infusion. As a consequence, we developed a second clinical trial that then integrates the administration of T-cells that are specifically generated in the laboratory to recognize WT1. This trial now is applicable for patients with what we call relapsed refractory multiple myeloma or plasma cell leukemia, as discussed. And both these trials are coming to an end because they reach the accrual pretty soon. So now what we learned now is that the WT1 specific T cells are safe, so we will apply this approach to patients with multiple myeloma at an earlier stage because they seem to be effective, they are safe, and the risk of graft versus host disease is really low. Now, while we are doing the next step of clinical trial, we'll plan to improve upon this even further by saying if we now have the capacity to transduce these T cells that are recognizing WT1 with a gene that produces the interleukin-12, then we have the detonator at the time that will hopefully even lead to better outcome with the same risk profile and the same amount of limited side effects. So the overall goal is very simple. We want to cure these diseases, and the allogeneic transplant as a platform has certainly the potential to cure a disease. But if we now build in immunotherapeutic approaches specifically targeting these tumor cells, then I think we have a shot to do that.
Well, we love that goal as patients. We love that goal, to cure it and it's not a chronic disease. So now with patients in the second set, when will you begin this clinical trial or recruiting for that? And then if you're able to now avoid some of the common pitfalls of graft versus host, do you have any age restrictions or physical restrictions on that clinical trial?
Well, there's two aspects to this. Obviously, you think a little differently talking to a patient that is 45 years old, and with standard of care, you have another 3 years to give with drugs, I mean, and compared to somebody who is 75 years old and can be having a really good quality of life for another 3 to 5 years with drugs. Mm-hmm. If you tell a 35-year-old patient, with the best drug combinations, because you have high-risk cytogenetics, the risk of relapse is very high, I can give you 3 years, he will just say, that is not good enough.
Right.
So from that aspect, there are some limitations. The tolerance of this transplant itself, or the age limit on my clinical trials, I just raised it to 72 years old because it was really very, very well tolerated, which speaks in itself also. But it also taken into consideration that the tolerance is better in patients that are younger. And all in all, what the overall results now show on all the patients transplanted is that the outcome is of this transplant is better if you don't wait for 4 or 5 relapses. You want to do this relatively early. And again, as in the beginning of our conversation, I pointed really out that the disease dynamic changes once you have a relapsed multiple myeloma after, for example, an autologous transplant. That's where you want to start thinking differently. Mm-hmm. There are drugs that can keep you in remission after that. Not everybody, and that's really critical for me to point out at this point, not everybody should have an allogeneic transplant with our approach here, but those who had multiple relapses or have high-risk cytogenetics are stable, and their kidney function, their lung function, and their heart function is fine, should start thinking about this rather than to wait for another 2 or 3 relapses that will ultimately occur.
Mm-hmm. And let's talk about cytogenetics. Are there any other high-risk features that you see as this being particularly good for? I mean, if it's plasma cell leukemia, then but a gene deletion 17 or
exactly right. So there are markers that predict that the disease will have a high potential and propensity to come back. And the P53 gene or the deletion 17P. There are other markers, 1Q25, 1Q23, T14, 16, are all indicators that you want to start thinking about this at an earlier time point. And one part of my clinical trial where we do T-cell depleted transplants is what we call an upfront transplant. So if patients are really young, less than 55 years, and have these high-risk cytogenetics, you know that with standard of care and an autologous transplant, the disease will come back sooner than later. And therefore, we now transplant those patients after the autologous transplant if we have appropriate donors with the T-cell depleted allogeneic transplant.
Mm-hmm. And we were asking this question. Our last show was about CAR T cells that are targeting the CS1 protein, and Gary asked some relevant questions about pricing, how much it costs to be able to do this type of research. Can you talk about different milestones that you might see on the horizon and how much those milestones cost to achieve?
Yes, it's the good news now is for patients who undergo allogeneic transplantation. The transplantation is covered by the insurance company, with the exception of Medicare. They haven't done that step yet, but in the beginning I had some problems to get this approved. Right now, most of the patients get this covered by their insurance. So those costs are already accounted for. For us, it's really the laboratory costs and the experimental strategy that we have to generate these T cells, to monitor the immune responses. That requires skilled personnel in the laboratory, that requires research study assistance, and so on. So the generation of the T cells itself is, inducing some costs. So if I had a clinical trial now with a T-cell depleted transplant and performing the administration of the WH1 specific T cells, depending on the amount of patients you enroll, let's just say 30 patients, you may talk about $500,000 for a trial like this that has to cover all the other costs to generate the cells, to infuse the cells, to cover for the expenses and personnel.
Mm-hmm. Okay, well, it's interesting learning about that from a patient perspective because we usually don't think about that part.
and the patients don't get charged. So the hospital, as long as it's experimental trial, so my funds and the hospital has to, basically me, has to cover the strategy and the idea to do this, and therefore to have these funds in the bank is really important before you can open this trial.
Mm-hmm.
All we need is one Sam Walton to get sick, and we'll have plenty of money.
That's right, but
well, we don't wish it on anybody, do we?
That's right.
So, Cynthia, Gary, or Pat, do you have any follow-up questions? I'm sure you do.
No, I'm good. This has been very enlightening, and it's hopeful and encouraging, and we appreciate your hard work, Doctor.
Thank you very much. I hope I made it understandable. I'm not really sure how lifted off I sometimes give my answers, but I try to keep it on a understandable level.
You made it much easier than reading that presentation that you provided.
Okay.
And our ability to ask the questions that clarified that. So we really do appreciate that. I had a couple questions, and one of which is based on Be the Match, Memorial Sloan Kettering Cancer Center does a pretty good job. Their 1-year survival for the allo is 70.3%, and compared to other people, that's pretty darn good. That's 30%. But
yes.
If you applied this kind of a strategy, is that 30% who die is that usually due to graft versus host?
No, that's basically, but that's exactly the point that I was making earlier. So the 70% outcome is really as good as it can get because we avoid graft versus host disease. This 70% alludes to all patients transplanted. This is not particular multiple myeloma. Those are other diseases. Yeah. So that basically is because the rate at 1 year is lower because patients die of complications from graft versus host disease. Since we can avoid that, we are really up there. So there is still, obviously, two aspects that can reduce it by 30%, and the one is that you have a really advanced disease. No matter what you do, you relapse. That's one part of this patient cohort. And another group is another complication that we encounter are complications with regard to infections that develop. And that is also really a key aspect of it. If patients with advanced leukemia or multiple relapses of leukemia get transplanted, they are more prone to get complications of viral infections and so forth. And therefore, you take this into account, and the dropout rate is about 30%.
Okay, so that in your analysis, you said something about 18% was
that's in my
related mortality.
Yeah, so this is specifically now for patients undergoing transplant for multiple myeloma. I'm about to submit a manuscript to summarize the clinical outcome of 44 patients transplanted with multiple relapsed disease, and some of these, or most of these patients, in fact, had more than 5 lines, up to 10 lines of treatment because they relapsed 6 times and more. And all what this shows that the graft versus host disease rate on all patients transplanted is only 2%. That is unheard of, and the biggest complication, frankly, is what is called chronic graft versus host disease, which leads to complications like dry eyes, dry mouth, stiff skin. The quality of life of these patients is really not good if you have chronic graft versus host disease, and they sometimes wonder whether or not they really benefit from a longer life, but not so good quality of life. In my study, there is not one patient with chronic graft versus host disease, and that makes, again, that's 0%. This makes the point again that you do not need to have this to prevent relapse. Okay. The 18% you allude to are the ones that have complications from infectious complications. Of all patients transplanted, it's 18%. But we also had within these cohort unfortunate situations that basically are unavoidable. 2 patients got infected with the flu from visitors and couldn't recover from it early post-transplant. And one patient just decided to go overseas despite of medical advice not to do so, and came back with a really bad infection and did not survive that. So those situations are hard to avoid. But so we are, usually with the T-cell depleted transplant, we have a what we call a non-transplant related mortality, which includes the infections of approximately 10%.
Okay, versus the 30% that you had for all allo transplants.
That includes also the patients that die of relapse disease. So that is a 10%.
Remarkable. I was trying to surmise because I looked at some of your data. It says 31% of patients at 2 years.
Correct.
Which is 5 of 16 are alive at 2 years. And that didn't quite equate to your 18%, but that's
correct.
So I don't, I can't. I was having, because to me that was, unless they all died in the second year,
Yeah, I'm not sure which data where these are, what they are applied to.
Report. It was 31% of all patients at 2 years.
Mm-hmm. But this includes all transplant recipients for all diseases. That is not specifically for the patients with multiple myeloma. That is all the diseases.
Okay, that was the other.
And that's a broader spectrum, yeah.
Yeah, this was
right,
just in your analysis, it stated this, and I was I was a little confused making trying to make that equate to your 18% or make it equate to the 16 patients, 5 of which had plasma cell leukemia and didn't even make it to T-cell infusion.
Yeah, that is obviously, so that's important to point out that at this point, not everybody with plasma cell leukemia has a complete remission and a long-lasting response because the disease is really that aggressive. And a lot of patients, or some patients, come back with disease after the allogeneic transplant before you have a chance to give the T cells because it is such an aggressive disease. So that leads to the next question. That's why the IL-12 may come down with some benefits, but also how early would be best to administer these T cells. So maybe we should not wait 6 weeks or 8 weeks because there was already a 30% drop off of patients that relapsed within the short time period. But
all 16 patients, plasma cell leukemia patients.
Of the 16, there were 7 patients with plasma cell leukemia, and the rest had what we call a relapsed refractory multiple myeloma.
Okay, so you had much better luck with myeloma than you did with plasma cell leukemia.
No, in fact, the patients with primary and secondary plasma cell leukemia, half of them are in complete remission, and it's a really impressive response.
I have a question. Does everyone that you give the WT1 T cells to show some kind of immune response to them, or are there some non-responders?
Yeah, that's a really good question also, and that leads back to the answer is not everybody did, but those who do are doing clinically well. Those who do not have a detectable T cell response are not benefiting from the T cells.
And we don't know why.
We don't know. That is not entirely clear at this point, but that's also under investigation. That may gets a little bit more in detailed immunology. Sometimes some of the peptides that are derived from WT1 are more immunogenic in the context of what we call HLA. That is the markers, we look for donor and patient matching. So some of them present this peptide stronger to the T cells than others, and therefore the ones who have the appropriate HLA typing have a stronger and better immune response. These are all questions and really important aspects of it that arise of all this work that we are doing right now.
Right. Great work that you're doing. Also, what kind of side effects have the patients experienced once they saw an immune response to the T cells?
Interestingly enough, no side effects.
Amazing.
Oh, wow.
Just clinical responses. There are no side effects, particularly We have not observed any cytokine release syndrome, which the CAR T-cell therapy can do, or any kidney dysfunction, or acute or chronic graft-versus-host disease.
Wow. Okay, because that's what the CAR T-cells, they were seeing some of those
yes.
side effects.
Yes.
They were talking about, like, with the CAR T-cells, once they're infused in your body, there is an expansion of them. Or does the same thing happen with the WT1 T-cells? Do they expand once in?
Absolutely, and that gets back to the biology of these T-cells and the difference between a chemotherapy and a drug. The chemotherapy drug just gets eliminated over time. In fact, the T-cells can expand over time in the system. Therefore, you get more over time.
And they just come out when you need them, and then they go away when you don't.
They do their business. They kill the tumor cells, and then they disappear. And if there is a tumor cell that develops over time or can be found, then they have the capacity to come out. That's basically the reason why the principle is the vaccination of against viruses, or you were exposed as a child to a specific measles virus, for example, and then you get exposed again and later during your life, you're not going to get a second wave of measles because your immune system is on standby and is just able to eliminate the virus before it makes you really sick. And that's what we hope. I observed it in some patients. I cannot generalize this at this point, but the principle surely could apply to exactly the same approach. We have them, they survive, and they come out, and they do the tumor surveillance.
Sounds great. Thanks.
Now, we have some write-in questions, and you may have covered some of this already, but from Jack, he was asking, is there a way that you could ultimately give this therapy without transplant, maybe a very good partial remission from induction therapy, and then proceed? You covered this a little already.
Yeah. At this point, it's difficult to predict, but we will certainly test this. I mean, we talked a little bit about the CAR T-cells approaches. That would be more an approach to utilize in the autologous setting or to treat the disease with the patient's own cells. Mm-hmm. Whether or not that's applicable to the WH1-specific T-cells clearly needs to be tested. There is no scientific evidence at this point that it is possible. But certainly we have the capacity and the ability to generate these cells from the patient, and we will certainly test this. And if this has a comparable outcome than the CAR T-cell therapy, then we will develop clinical trials to expand this.
And would you do it in a mouse model first, or no?
I'm sorry, I didn't hear the first part of your question.
Would you do it in a mouse model first or not? I don't know. Have you done? You talked about a mouse model.
From scientific aspects, it's always good to do this. So we have three phases. Basically, you do the laboratory work, and then you test it in the mouse, and then you go to clinical trials in human beings. That is watertight approach. We did a lot of mouse experiments, and I'm not really sure we have to do it in every single circumstance, but it just recapitulates work that we have done before. But obviously, since this is untouched ground, it would be worthwhile to have T-cells from an individual in a mouse, in a humanized mouse model that allows you to show that the T-cells really go to the tumor, and that we like to test in this circumstance.
Yeah, has your research historically shown that what happens with the mouse also happens with the in your human trials? I mean, is it pretty good at doing that?
The environment. So if you talk to a mouse doctor who is focusing on laboratory work, he will say yes. If you talk to somebody who applies this more into the human beings, the environment obviously is very different in the human being. So it's not necessarily transferable in every single circumstance, but it's basically the principle is to show that the cells have the capacity to go through the bloodstream and to home to the tumor, And if you can show that, then I think it's worthwhile to get it to the next level and administer these cells in the human being.
Okay.
Well, Dr. Hofmeister showed that, and it was with some remarkable results with those CAR Ts. So that's why I asked that question.
Absolutely, no question about that.
And Jack's second question was: this proposed next upcoming trial is for like primary plasma cell leukemia, secondary plasma cell leukemia, and relapsed refractory myeloma, correct?
That's the plan. Yes, that we would target this high risk category of diseases first.
Okay. All right. Well, unless anyone has any other. Oh, okay, go ahead, Cynthia.
I do have one last question. Would there be any way in the distant future, if this type of therapy does prove to work, to have a factory manufactured type T cell so that you don't need to make it individual per person and cut down the expenses?
Wonderful question, and in fact, companies are now heavily involved to look into this market. We are right now at our place at Memorial Sloan Kettering in intense negotiation with companies that would like to do exactly what you're doing, what you're suggesting, to take over the pattern, to license it, generate these cells, and then make it basically open it to the market. Right now, all the patients that would need this treatment have to come to our place for the treatment of it. But if it gets licensed and it can be expanded, then we have the capacity to ship these cells to centers that can administer these cells. That is, in fact, not distant future anymore.
Okay, great. That sounds exciting too.
Yes, very nice.
It's remarkable. Dr. Kohne, we're just so impressed that you've been able to see results in plasma cell leukemia patients. I think that alone is just stunning, to be able to see that kind of response in plasma cell leukemia patients who really have no options and a few weeks to live. It's just truly stunning.
Yeah, no, I'm also very happy and really honored to observe this and have this contact to my patients and having a discussion and talk about the limited time that is left, and then 2-3 years later you still are able to see them in remission and talk to them is just puts you in a completely different category of why, and the question why you're doing all of this. It's just a wonderful experience.
Truly remarkable, Doctor.
That is why you're doing this, and that's why we're loving that you're doing this.
Thank you very much.
We're just so thrilled. Well, we are so grateful for you that you joined us today. Thank you so much for explaining your research in such great and easy to understand terms.
No, thank you for including me and for inviting me to give me a chance to talk about it. I'm very honored to do that.
Well, we're very appreciative. And we will be providing the full transcript as we are finished in a few days, so watch for that, and then we'll include the link to the video so you can learn a little bit more about that. But we're very thankful. Thank you for...
Truly remarkable, Doctor.
Thank you for listening to Myeloma Crowd Radio and the new Myeloma Crowd Research Initiative series. We believe that patients can help support the discovery of a cure, and we encourage you to become involved.
Judy was boring.
Hello.
Then Judy discovered ChumbaCasino.com.
It's my little escape.
Now Judy's the life of the party.
Oh, baby, mama's bringing home the bacon.
Whoa, take it easy, Judy. The Chumba life is for everybody. So go to ChumbaCasino.com and play over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.